right. Well, I know, Quentin, that you can take up this time, so I better get us started. Thank you, everybody, for joining today. My name is Carrie Smith, and I'm part of the Ethics Services team here at Providence Healthcare. And I'm joining you today from Mount St. Joseph's Hospital in the unceded ancestral territories of the Coast Salish people. In particular, those are the Squamish, Musqueam, and Tsleil-Waututh nations. And I'm grateful for the opportunity to be here on this land and for the stewardship provided by the Coast Salish peoples for it. I want to go over a couple brief housekeeping items before Dr. Jennis begins his talk today on non-maleficence. So that's my first note, is that this is a bit of a schedule change. This was listed as the justice talk, but that's going to be next week. We just found that we couldn't quite get Quentin couldn't quite get the beneficence and non-maleficence all in one. So today we're going to talk about non-maleficence. Next session on the 21st will be on justice. As most of you know, we will offer a certificate of completion for this series to those who attend all the sessions and would like one. Later in this session, we'll invite people to identify themselves to us if they would like their attendance noted for a receipt of our certificate at the end, and there's no requirement that you do so. After each live session is completed, we are making recordings available through another course on Learning Hub. So this is an online course, and you'll notice in Learning Hub, there's both classroom and online. This one's considered a classroom. The other course is an online course, and it's called Principles to Practice: An Introduction to Healthcare Ethics, a PhD Ethics Services seminar series. It has 10 modules, one for each webinar. So you can view this video or this lecture in a video recording, and there are short quizzes for each one to be completed for those who want their attendance noted towards a certificate of completion. And again, the quiz is not mandatory. You only do it to demonstrate that you have watched the video and to get the certificate. So during this recording, no identifying information on participants will be included in the recording, and any questions or comments that you submit to the question and answer category there will be anonymous, and any comments to the presenter and host will not be visible to the larger group. The structure of the session is the same as it has been, approximately a 50-hour talk provided by Dr. Jennis, followed by a question and answer session. Please write your questions in the Q&A section to be addressed at the end of the session, and you can submit those questions anonymously. And at the end of the session, we would really appreciate you answering a brief survey. It's only five questions and should just take you a moment. It's my pleasure again to welcome back Dr. Quentin Jennis, who's a physician ethicist and an emergency physician at Providence Healthcare. He holds a Master of Letters from the University of St. Andrews with a research focus in bioethics, and is a published writer in journals of philosophy of medicine, bioethics, and medical science. Thank you, and over to you, Dr. Jennis.
Thank you so much, Carrie. The only correction I have, as Carrie said, is a 50-hour talk, and I know it often feels like 50
it totally
hours.
Isn't. Sorry.
No, I know but that was, sometimes the feedback comes through. I know it often feels like a 50-hour talk. I'll try to keep, my goal is always to be 45 minutes, but it does always seem to stretch to fill the time. So we'll try to keep it that way today as well. Thanks as always for all the work and the introduction. And I apologize again from my end about this being billed as our justice talk, and it in fact being non-maleficence. I'll explain more about why in a second, but any sort of incongruity is totally on me, and the fact that my outline did not match the content I could actually cover in a certain amount of time. As always, I don't have any professional disclosures or mitigations at the beginning. As always, here's a big outline just to help orient us to what we're doing today. So just to run through quite briefly, this is our 10 seminar conversation around bioethics as part of our conversation within Providence Healthcare. I really am a big believer that in order to cultivate a rich space to talk about ethics or to wrestle with the good, it's really important to start at the beginning. And so our first 3 sessions were big ideas sessions where we picked up some basic questions. What is ethics? What is bioethics? And what is Catholic bioethics? And now I would say we're in the midst of our second main chunk of ideas, where we're considering the principalist theory by 2 American thinkers named Tom Beauchamp and James Childress. That is the dominant theory for bioethics in our time. And so this is a theory that was initially sort of published in the early 1970s, so relatively recently. in terms of the history of philosophy, and this is still an evolving conversation. But as we have seen, and as we will continue to see, almost all bioethics conversations in our time, if not all, reference or directly relate to these principles. And so if you want to understand the conversation of bioethics in our time, it's important to carefully examine this framework and the so-called four principles. Those principles are principle of respect for personal autonomy, beneficence, non-maleficence, and justice. And so we're kind of through two of those and working on our third one, non-maleficence, today. As you can see from the outline, initially, last session was supposed to be one where we discussed beneficence and non-maleficence. But as I sort of said last time, when I wrote that outline, I bit off more than I could chew. And so in real time, we've sort of separated those out into two separate seminars. And then next time, we'll talk about justice. As always, again, just briefly, if you have any particular questions or cases that don't fit into our Q&A time at the end of this particular seminar structure, or you feel would be better suited to sending in an email, please send us an email. And finally, to get out of the way of these introductory comments, is our outline for today. And this looks a lot like our outline for last seminar, and there will be some considerable continuity with our conversation from last seminar. So if you weren't there, that's totally fine. As Carrie said, the videos are up online on the Other Learning Hub course. But what we're going to do today is we're going to, again, have a bit of a preamble and a relevant review to set up what we're saying today, to pick up some strands and some threads from prior seminars. And then secondly, we're going to dive specifically into non-maleficence. And so our two subpoints there, we're going to ask the basic important question: what does non-maleficence mean? Where's the harm? And secondly, we're going to consider what I've called a positive sketch of non-maleficence. Now, by way of preamble, I want to just remind you of this strange fuzzy photo of a bat. And this relates to a story that I told last week, and I'm not going to tell the story again, although I think it's quite a good story. But I want to just remind you of this image of the bat in the ICU. So the headline on the story is, one time I was in a very sterile ICU and there was a bat sitting on the floor. And so a bat in the ICU is an image I keep in my mind always of some kind of a structure or system that wants to be very airtight. But the bat in the ICU is the obvious flaw, the obvious, contaminant. And I think whenever we consider any series of ideas, we want to come to new ideas or new structures or framework with a humble learning growth mindset to ask, what can we learn from any given argument or view of the good? We also should come to any new argument or framework or whatnot with a critical eye to where the holes are or the challenges are. And so when someone presents me with a new idea, or I read a book of philosophy, I always want to ask myself, where is the bat in this ICU? This sort of view of the good that might seem appealing, are there areas where it might not hold water? And so as we go through today and our subsequent sessions, when we pick up ideas, we're going to ask ourselves at times, where is the bat in this ICU? Relevant review. Here again is a picture that I put up last week. This is a framework for ethical decision making, and this is a framework that's used in Providence Health. As we said last week, the sort of left side, steps 1 through 4, is some of the really, really critically important, meaty on the ground work of doing ethics well. And as I've emphasized previously, I think in the context of any interaction in a healthcare space, the building of trust and the sort of gathering of information, the establishment of trust and understanding of the situation is absolutely a critical, necessary thing. And so to carefully step through the process of identifying the issues, listening to stakeholders, humbly acknowledging your own biases, feelings, and worldviews, and then carefully, appropriately gathering and clarifying the facts. This is the bulk of the actual work, and doing this stuff well enables you to engage into particular ethical dilemmas and have so much better and with so much less hurdles. But today, and in the last week and next week as well, we're really focusing in on step 5, where you analyze an ethical dilemma in light of ethical principles. And so an ethical dilemma is not a situation where there's one clearly good outcome and one clearly bad outcome. An ethical dilemma is a situation where there are competing goods or competing views of the good or competing principles. And so when we come to these situations, it helps us to develop and utilize precise language to describe the goods or various goods that exist in tension. And so we see in this step number 5, I try to identify which principles in play and then which carry most weight in a situation. And here, amongst many other places, we again encounter the 4 so-called principles of bioethics. So in our first session on these principles, there was now 2 or 3 sessions ago, we picked up the question of the principle of respect, reversible autonomy. And then last seminar, we picked up the idea, the principle of beneficence. Now, we have already identified some potential bats in the ICU of this 4 principle theory. And one of the ones I've talked about before, but just I'm going to review very briefly today, is this idea that for Beauchamp and Childress, when principles compete with each other, the principle that really matters for them is the principle of respect for personal autonomy, that they imported into the bioethics space, the sort of political libertarian philosophy that says other things might matter, but really the thing that ultimately matters and ethical dilemmas is just and only autonomy. And so here's a quote I put up before. We're just going to review the bolded parts. Commentators have thus argued that this conception of autonomy is totalizing, subordinating all other principles for consideration. And this is just a brief review of some things that we've said about these principles along the way. Something else that we've mentioned in passing, but I wanted to give a tiny bit more attention to today, is some principles of this, or some critiques of this theory, some potential bats in this ICU that are not criticisms of these particular principles in themselves, but a critique of principalism in general. So there are different ways to do ethics. There are different ways to approach the ethical question. And for those of you who've been following along, we've talked at various points in this seminar series about the 3 ship questions. And so if you want to have a robust view of the good, you want to know, how do I keep each ship shape? How do I prevent my ships from bumping into each other? But you also need to reflect on and answer questions of ultimate moral significance. Where are my ships going? And sometimes when people conceive of ethics simply in terms of principles, when they say, we don't have to think about sort of high theories of the good, all we need to do is just understand these sort of absolute prima facie principles and then follow them. There are some strengths to principled ethics, but there are some also potential weaknesses. And one criticism of Beauchamp and Childress that is written by this philosophy, last name Hai-Rai, I'm sorry if I pronounced that wrong, but says, by ignoring moral virtues and thereby all deliberations about the ideal nature of the good, virtuous human being, Beauchamp and Childress left their views wide open to accusations of short-sighted hedonism, excessive individualism, and sneaking nihilism. And so when there is a disconnect, when you lose sight of questions of what is ultimately good or true or beautiful or healthy or helpful, and instead you just say, here's some prima facie principles, some principles that are obviously and necessarily true, and you just follow them, this can sort of open these types of frameworks up to criticisms of this type. Now, if this criticism seems off the mark to you, I think it's relevant to consider a quote from Tom Beauchamp himself, who 30 or so years after writing his book on bioethics said himself in a different publication, he said, this moral theory, part of the landscape of bioethics, I expect to vanish soon because it is serving no useful purpose. And so we have Tom Beauchamp, who was, again, one of the 2 authors of this theory, himself saying that all we need is just these absolute principles, and any sort of higher or deeper, depending on your metaphor, any higher or deeper moral theory is actually not necessary. It is not necessary to consider what is actually good or what actually promotes peace or justice or reconciliation or trust. All we need is to understand and to adhere to these principles. Now, there might be several problems or questions that come to your mind when you read this criticism of principalism and this quote by Tom Beauchamp. But I think one of the most obvious responses to this quote by Tom Beauchamp is to say that principles are only given moral content when they are attached to a particular good. And we saw this last week when we talked about the principle of beneficence. If ethics is a place where we come to the table and we say, how do we name the good? How do we be good? How do we do good? then proposing a principle of ethics that's called beneficence, that the content of beneficence says, do good, try to achieve good, that doesn't actually help you very much. It doesn't sort of punt the ball steps down the field unless beneficence is attached to some higher or deeper moral theory that helps us know what the good is. And this prompts the necessity of considering what I've called along the way teleological ethics. If you want to know what's good for a doctor to do, you need to know what a doctor is for. What is beneficence? And one common critique of principlism is when you just have principles disconnected from any sort of higher theory of the good, you can use principles and these principles to defend almost anything. So unless the principles have particular determinative content, you can use ethical principles to defend or advocate for almost anything, and therefore they're not very helpful for determining ethical behavior. And we'll see that specifically when we consider non-maleficence today. So last week, as I said, we talked about the principle of beneficence that most broadly says, try to do good. Try to achieve good in the lives of your patients. And what I tried to establish last week is that there are two particular underlying goods that should give content to beneficence and therefore make it a helpful and useful principle for bioethics. And we discussed last seminar the idea that one of the particular goods for the space between a doctor and a patient, for example, is the good of health. And so when we ask, what does it mean to be beneficent? What does it mean that there is an ethical imperative, a duty to be beneficent, that is given content by a commitment to health? What it means to be beneficent is to try to produce health in your patients specifically. Secondly, we talked about this idea of what I've called inviolable human dignity. And again, there are different conceptions of what dignity is and where it comes from. But I believe that a good, robust view of the good in a healthcare space must be rooted in a view of inviolable human value and dignity. And that is a specific, particular belief that is attached to specific, particular moral theory and philosophy that gives particular content to the notion of beneficence. And last week, we picked up 3 cases, and I'm going to review the cases for you again briefly. If you have more questions about them, you can go back last week. So the first case was a case where someone comes in to the emergency department who has a mild sinusitis that does not require antibiotics by, in the assessment of any medical evidence or guidelines, but says to the physician, well, I want antibiotics and it's my choice. And we ask the question in the case where the patient says, I want antibiotics for my particular mild sinusitis, and the doctor says, I don't think that's in keeping with your health. What does beneficence call us to? What good does beneficence adhere to? Does it adhere to the good of autonomy, or does it adhere to the good of health? Secondly, we talked about this case of a patient who had multiple life-limiting diagnoses, whose life expectancy was somewhere in the matter of months, who came in with delirium secondary to a urinary tract infection, and who was incidentally found to have a lung cancer. And the opinion of the sort of relevant medical experts was that this incidentally found lung cancer was unlikely to impact the patient's prognosis and was unlikely to cause the patient significant symptoms prior to the patient likely dying from another cause. And the family requested to the medical team that the patient not be told the diagnosis of this incidentally found lung cancer, because the family said that the patient had always had a real fear of cancer, and they felt that her last months, knowing of this diagnosis, would further her suffering. And so again, we asked, in an ethical dilemma, a situation like this, how do we define beneficence? What does it mean to be beneficent? What are the underlying goods that inform beneficence? And thirdly, we talked about a case of a patient with COVID, a patient who, relates to a case of someone who I saw in one of the emergency departments I work in during the sort of height of one of the waves of COVID, but a patient who had quite significant COVID, I would say not ICU sick, but certainly hospital admission level of sick, who did not believe that COVID was a real diagnosis, would definitely wanted to be admitted to hospital and wanted certain therapies, but declined and refused, I would say, to adhere to sort of infection control guidelines, refused a lot of medical interventions that were recommended, refuse to wear a mask, and those kinds of things. And so we ask the question, in this difficult ethical situation, what does it mean to be beneficent? And again, we're going to pick up these cases a bit more today. If you want to know more about them, you can go back and listen to last seminar. Today, with all of that preamble and relevant review being said, we are picking up what I have sort of set up as the third. I know it's number 2 in this particular list, but the third principle of clinical ethics, as set up by Beecham and Childress, and this principle is called the principle of non-maleficence. And so, what we're going to do today is, first of all, as always, when we consider a new idea or term, we're going to ask, what does non-maleficence mean? And then secondly, I'm going to try to outline what I've called a positive sketch of non-maleficence, a way that this principle can be helpful for us. So first of all, non-maleficence, what does non-maleficence mean? Well, Beecham and Childress want to quite directly use this principle to adhere their ethical theory to the Hippocratic tradition. And so as we discussed in seminar number 2, people have been doing what we now call bioethics for a very, very, very long time, at least since Hippocrates and probably before. But associated with the Hippocratic tradition is this Latin phrase, primum non nocere, which means in English, first do no harm. And many thinkers and bioethicists sort of have said that this is part of the Hippocratic Oath. Incidentally, this phrase is actually not in the Hippocratic Oath itself. And this is probably a bit of a nitpick and not relevant to the sort of general thesis I'm trying to discuss today. But many people have said this is at the beginning of the Hippocratic Oath. It's actually not. This phrase in itself is not in the Hippocratic Oath. But I think it is certainly fair to say that this is a general principle of ethics that comes to us from the Hippocratic tradition. And so the nitpick is just that quote is actually not there. But what we can see, in the prior seminar, we looked at the whole Hippocratic Oath in a bit more detail. So this is just a quote that I pulled out of the middle of the Hippocratic Oath. But we see that the Hippocratic Oath does indeed say, and I'll just read the bolded parts here, but it says, I will do no harm. And then just the next sentence, and I will abstain from all intentional wrongdoing and harm. And so this was part of the particular professional ethic of Hippocratic physicians, and therefore I think it's very reasonable for somebody in our time picking up a principle of non-maleficence to say that there is continuity between this Hippocratic idea, if not that a Latin quote in itself, and this general idea of first doing no harm. And so for Beecham and Childress, they say quite directly, non-maleficence is a principle that means you should do no harm to your patient. And to quote Beecham and Childress themselves, when they define what non-maleficence means, they say, perhaps very slightly differently, they say everyone has a duty to prevent harm insofar as this is possible without undue risk to oneself. Now, if we had more time, it would be interesting to ask, is there a slight or subtle difference between the Hippocratic phrasing, do no harm, and the Beecham and Childress phrasing, duty to prevent harm? Is that truly a synonymous sentiment, or is there a subtle difference? But I think there is, at the very least, very, very significant overlap between these ideas. Now, one of the questions I think that we would rightly have to reading this simple definition, okay, we agree, we should be non-maleficent. What does it mean to be non-maleficent? It means not to harm the people who we try to care for in medical spaces and or to try to prevent harm for them. But then I think it's very reasonable to ask, what is harm? What does it mean to harm someone? And again, here we see we have asserted a principle of non-maleficence, but then in order to have determinative content, the principle of non-maleficence needs to be attached to some theory of the good and the bad, the right and the wrong. And if it is not attached to some deeper or higher theory, then you can, and people do, use the principle of non-maleficence to defend or to advocate for almost anything. And so, for example, looking at the 3 cases we considered last week, if you consider the first case, the case of the very well patient with a very mild sinusitis that is almost certainly in any expert assessment not a bacterial sinusitis, and in any guidelines does not require antibiotics. And according to any medical evidence or guidelines, the antibiotic would be more likely to harm the patient in terms of causing reactions or side effects than they would be to help the patient. with his symptoms. You have this case where the patient says, I want the antibiotics. I'm less interested in your sort of guidelines. I feel like I know my own sinuses and I think I need antibiotics. And the physician says, according to all medical evidence and expertise and guidelines and whatever, the antibiotics are not likely to help you. And if anything, are cause you increased risk of harm in terms of symptoms and those kinds of things. I want you to think for yourself for a moment. What do you think the principle of non-maleficence would compel you to do in this situation? I think that in a vacuum, you could very easily use the principle of non-maleficence to defend any course of action in this situation. You could very easily say, my job as a physician is to do what minimizes harm in terms of the health of the patient, and to use my judgment and my role as a medical expert to make the decision that reduces or prevents harm, as Beecham and Childress said. Therefore, even if this competent patient has a very different expectation, and even if it makes him upset or even angry with me, I will not provide him with antibiotics because of the principle of non-maleficence. You could also very easily say there is a significant harm, which is the harm of paternalism. And Beecham and Childress are very interested in preventing from this harm. And so the harm of me imposing a particular view on the patient who is competent and educated and understands the decision suggests that I should prescribe him with antibiotics if in his reasoned judgment, he should have them. And therefore, non-maleficence is a principle that might compel me to prescribe antibiotics in this situation. So you can see here that unless non-maleficence is attached to some deeper or higher theory of the good, you could use it to defend any course of action. Secondly, with case number 2, we have a case of a patient who is, again, has a, oh, was someone connecting to audio? Okay, I'll just keep going. I hope everyone can hear me. We have a case of someone who has a temporary delirium that will presumably resolve, that's presumably related to an acute bacterial illness, who is found to have this new lung mass that is most likely to be a lung cancer. And the family says to the physician, we love and care for this elderly person. We believe that telling her about this diagnosis would not in any way change kind of her health journey or her symptoms or her experience, but it would lead her to profound additional suffering and fear in her last months of life. And so you should not tell her this piece of medical information about her own body, because to do so would be to harm her. So you could again, and I think you should ask yourself, what do you think non-maleficence compels you to in this situation? But I think you can again see how you could appeal to non-maleficence to advocate for completely different or mutually exclusive courses of action in this case. So you could say, based on the family who knows the patient's values and who knows her and cares for her, to tell her this diagnosis would not change her, it will not change her symptoms, it will not change her medical therapies. But if it will produce significant suffering and fear over the last months of her life, that would be to cause her significant harm. Therefore, the principle of non-maleficence suggests I should withhold this information from the patient and not tell her this information. Conversely, obviously, you could appeal to the principle of non-maleficence to say, no, this is a patient who, once she's recovered from her delirium, will be a competent, autonomous decision maker who has the primary right to understand and to be told medical diagnoses and to make decisions about them. And it would be paternalistic and harmful to withhold information about her own health from her, even if her family thinks that we should. Finally, and we'll try to speed up here because I'm prone to going long, as we have already discussed today. The situation where we have a patient who is legitimately unwell, who requires oxygen for a presumed significant COVID diagnosis, but who has expectations of the system that places healthcare workers and places other patients at significant harm due to not wearing a mask and refusing to go to a COVID ward, and all of those other kinds of things. You can again see how a principle of non-maleficence could, if sort of are taken from different perspectives, suggest very different courses of action in a situation like this. wanted to introduce two new cases to you quickly today, because I think these are will be instructive as we think about non-maleficence. So again, I'm going to give you a hopefully short case stem with the relevant information. And these are cases that are, both of these cases are very, very common. I would say in the emergency department, I see a case that is like this at least every week. Both of these two cases I'm going to mention. And I think if you ask any of my colleagues, emergency physicians or nurses or other practitioners in settings like we work, they would say as well. So these are not rare out there situations. These are common situations. Our ethics frameworks should help us answer them. This is a picture of a knee, a random knee x-ray I got off Google. And this knee x-ray shows a knee that has significant osteoarthritis. So let us say that I see a patient in the emergency department and he works a job that requires him to be on his feet a lot. That's really hard on his knees. And he has chronic pain in his right knee. That's presumably due to moderate to advanced osteoarthritis. And he has had pain every day for a couple of years, but sometimes it flares. And he has acute on chronic pain for flares that sometimes last a couple of months. He, like many people in our context, is on a waiting list to see an orthopedic surgeon to discuss the possibility of a knee replacement, but that easily could be a year and a half away. The patient previously was using over-the-counter analgesia and ice and elevation and some of those good appropriate measures to treat his chronic pain due to osteoarthritis. But the patient comes into the emergency department requesting a prescription for something stronger. From the review of this patient's Pharmanet, the patient 2 weeks ago was at a walk-in clinic and was given a prescription for about a month or 6 weeks worth of hydromorphone to help get him through what he described and what the documentation described as an acute flare, acute on chronic pain, a flare of his knee pain due to osteoarthritis. And so the patient had somewhere between 4 and 6 weeks worth of hydromorphone. He comes to the emergency department 2 weeks later and says, my knee pain was really severe and the over-the-counter analgesia is just not cutting it. And the hydromorphone that I was prescribed worked great. And I used it a bit more than prescribed because it just gave me such relief, and I'm so grateful for it. And it enabled me to work without pain, which is something that hasn't happened to me in a couple of years. And so I just want a longer-term prescription for some hydromorphone to help me with my knee pain. So I want us together to take a second and to ask, what does non-maleficence mean in the context of this clinical encounter? And I think as thinking of some of the critiques that we discussed before, I think you could easily make arguments that non-maleficence could suggest multiple different courses of action in this case. But for you and for me, specifically related to this principle of non-maleficence, what do you think is the non-maleficent thing to do? Certainly, this is someone who is having very real, unfortunate, and likely severe pain to his knee. We also know, if you look at any guidelines or all the evidence and stuff from the past years of the opiates, that most people who end up having bad outcomes due to opiate use disorders got their first opiates from a physician. In many cases, those tragic stories started with physician encounters like this one. And we know all of the potential risks of being on these medications for chronic pain. But yeah, I think before we move on, just to take one moment to pause and say, what do you think specifically non-maleficence suggests in this case? Finally, another very common case that I see in the emergency department. I'll invent one that's sort of fictional, but is very similar again to things that we see in St. Paul's and Mount St. Joe's emergency departments most days. So this is a case of a young patient, we'll say a female patient in her early 20s, and the patient is previously otherwise healthy, but has a diagnosis of major depressive disorder. And the patient has had a really rough last couple of months for some relational and social reasons on top of having this underlying diagnosis. And this evening, this patient texted one of her dear friends saying, I'm about to take an overdose of some Tylenol to end my life, and just wanted to say goodbye. And the friend who dearly cares about this patient called a helpline. And one thing led to another, and police and EHS staff attended the patient's apartment building and brought her to the emergency department due to concerns about her safety. And the patient in the emergency department endorses or says that she has ongoing suicidal ideation, again, with a specific plan to end her life by taking Tylenol. But with that being said, she really does not want to be in the emergency department. She really does not want to be certified under the Mental Health Act or see a psychiatrist. And she is very specifically asking to go home and saying, in her reasoned judgment, as a person of sound mind, she should be allowed to leave the emergency department and return to her home. So I want to ask you again and take a moment to ask you, what do you think non-maleficence, specifically the responsibility to do no harm or to prevent harm for this patient, what do you think non-maleficence suggests you should do? And I want to add here just a tiny caveat that I don't want you to primarily start thinking about the criteria of the Mental Health Act. And so for those of you who are aware, our government has in place some very helpful and very clear legislation that helps guide us in situations like this. And we should be grateful for legislation when it's good and advocate for better laws and governance when those things need to grow or change. And so certainly on a day-to-day practice in terms of what we do in real life, obviously there are particular criteria that's laid out and defensible by law for when we are allowed to keep patients in the emergency department or in the hospital against their will, and when we're not to. But what I want us to see is that those particular laws are rooted in a particular view of the good. And so they are laws or things that are enacted by particular groups of people based on a particular vision of the good. And I suspect if we went around the conversation at this seminar, all of us could identify laws in our context in our country that we see as good and helpful and wonderful and in line with the good. And all of us could probably identify things that we would want to see change or grow or progress or whatever. And that suggests to us, obviously, that the conversation of ethics and law are not the same. We should hope and fight for societies where what is good and what is legal overlaps as much as possible. But to say what is good for this patient, this tragic situation of this person in the emergency department, to say what is good for her and what does the law say are not synonymous conversations. Our responsibility to care for her goes so far beyond just asking the question, is she certifiable under the Mental Health Act, yes or no? Our responsibility to her good is much higher and deeper than that. Excuse me. So with that in mind, I just want to pause again just for 1 second and ask, what do you think specifically non-maleficence means in this case? In this patient who's obviously at risk of a very, very significant harm by any medical definition if she leaves the emergency department, but really wants to do so. So with all of that sort of case review or case setup out of the way, I want to again come back to this primary question: what does non-maleficence mean? So non-maleficence, in the thinking of Beecham and Childress, and in most people who appeal to this principle, is basically a principled way of stating this imperative in the Hippocratic tradition that says, do no harm. But we've seen that it's not enough to assert a simple prima facie principle, well, do no harm, unless we can understand and engage in a rich and robust conversation about what the good is, about what harm is, and how to balance different and competing kinds of risks. So what is harm? I think the answer in the Hippocratic tradition was relatively straightforward. So this again may be pointing to some of this difference between doing harm and preventing harm. I think it's well accepted in the sort of scholarly community that in the Hippocratic Oath, what not doing harm meant was specifically defined by a particular adherence to promoting patient health. And that was the emphasis in the Hippocratic tradition. And so, again, they were teleological physicians. They would say, if you want to know what's good for something, you need to know what that thing is for. If you want to know what's good for a doctor, you need to know what a doctor is for. What is a doctor for? A doctor is someone whose practice exists to produce health. Harm in that context is that which violates or runs in the opposite direction of health. And so, one example of this that's very clearly in the Hippocratic Oath is they say, never will I administer a poison to anybody when asked to do so. And this is a quote that references a death and dying debate that was happening in ancient Greece, and of course is very much happening in our own time, in legal and societal and medical ethical contexts. And so one thing that defined the Hippocratic tradition as very unique in their context in ancient Greece was that they would not be involved in the practice that we now would call made in our country, although obviously that's not the same nomenclature that they use in ancient Greece. And so for them, there was a very direct line of association between saying, I will not do harm, acting with intent to end life, even in a context of significant suffering, is obviously harm by any sort of strictly biological definition, and therefore I will not do it as a physician. And so that is a relatively straightforward way of understanding harm, but certainly is the way that the Hippocratic physicians and their legacy over thousands of years saw it. Again, to just look back to our sort of 5 cases below, and I'm not going to go through all of them again in this context, but we can see quite clearly and briefly how defining non-maleficence in terms of health would suggest particular actions in this point of view. And so for the sinusitis patient, not harming the patient evokes the responsibility not to give the antibiotics if they're thought to produce greater harm than health. For the second one, not harming the patient would be, specifically referencing the medical well-being of the patient. And so if this incidentally found lung malignancy is unlikely to impact the patient's health, then non-maleficence might suggest we don't have a responsibility, an absolute ethical responsibility, to tell this patient of the diagnosis based on an overarching view of her good. And you can think through the other situations as well, in terms of what non-maleficence would compel you to do if you were defining harm in terms of health. Beecham and Childress, predictably, I think if you were here last week, you probably saw this particular move coming. But Beecham and Childress themselves say, quite directly, everyone has a duty to prevent harm where the nature of harm is in keeping with the competent values of the recipient of the action in question. And so for Beecham and Childress, the harm that they see as the most potent harm, the harm we have to protect against the most, is the harm of paternalism. And this is very much all over their writings, and I think brings up a term, paternalism, that is very important in our present bioethics conversations that we haven't discussed that much in these seminars so far. So I think it's time to consider it, at least for a minute here. And so paternalism is a word that literally means, I think this definition is a reasonable one, a policy or practice of people who in positions of authority or expertise of in some ways restricting the freedom or knowledge or responsibilities of people who are in subordinate or non-expert positions in the subordinate's supposed best interest. And paternalism etymologically relates to parentage. And so parents are paternalistic towards their children. They discipline them, they do things in their child's best interest, which the children presumably disagree with. So my 3-year-old, if I gave him absolute choice, he would eat, cookies for breakfast, lunch, and dinner, maybe a bit of ice cream, but basically it would be cookies all the way through. And so I think appropriately am paternalistic in my role as a father in trying to get some carrots and broccoli into him. So paternalism in certain contexts is obviously appropriate, but I think most people would say that in adult-to-adult relationships and not in the very sort of specific relationship between, of parentage, that paternalism is something that we should rightly see as deeply concerning. And paternalism, I think, produces harm for a whole large number of reasons, but I think one that I would want to focus on and emphasize is the way that paternalism can lead to the breaking of trust. And one thing that we've seen in the seminars as we've gone along is how disastrous it is for any good medical space, any good bioethical space, when there is a loss of trust between a doctor and a patient, or between a hospital and a patient, or between a healthcare system and patients. We tragically work in an environment, in a context, where many of our patients come to the hospital not trusting us. And I think specifically working at St. Paul's with the marginalized populations that I work with at St. Paul's. And I think it's important to acknowledge that many of those patients who come to the hospital who've experienced prior trauma or difficulty or marginalization or stigmatization, that they come in the door not trusting us. And tragically, a lot of that is our fault. And things that we as a system and as individuals have to consider soberly, and to do everything we can to conduct ourselves in such a way that inspires and then stewards trust in the future. And that's true at the level of individual interactions. And that's critically true at the level of systems and hospitals and policy. One of the real harms of paternalism is that it fails to steward and it can break trust. And it obviously is a significant problem. To be paternalistic, I think, often is to be maleficent and to harm the patients in ways that might not be strictly biological in terms of immediate medical outcomes, but are very real. And this is, for Beecham and Childress, the primary harm that they're interested in preventing when they assert a principle of non-maleficence. But having said that about paternalism, if this is true about the Beecham and Childress theory, then their non-maleficence principle is just another principle that accords to the higher good of autonomy. If the harm that they're interested in preventing is the harm of paternalism, which is obviously the counterpoint, the opposite of autonomous decision-making, then like beneficence last week, we see a framework where other principles stand underneath autonomy, which is the ultimate totalizing and guiding principle for ethics in this theory. What I want us to ask briefly before we move on is just to re-emphasize the ways that we need to consider transcending an autonomy-paternalism dichotomy. And I've said this before, and I'll say it again, an autonomy-paternalism dichotomy is always transcended in a relationship of trust. Beecham and Childress are informed in their view of the medical space by libertarian political philosophy. They see the medical space as inherently a technical, transactional space where the real question is the question of power. And I want to say that that is a shallow view of the medical space. Rather, we should embrace and invest in hopeful ethics narratives where the fundamental question is the question of establishment of trust. And so we should not see all of our ethics in terms of autonomy or paternalism. We should identify that paternalism is something we should be deeply concerned about, but also we should try to transcend this distinction in a relationship of trust. Second point, quickly, I want to provide you with not just sort of that point, which is similar to the point I made last week, but what I've called a positive sketch of non-maleficence. And I'm going to try to do so in an efficient manner. Firstly, and we're going to talk about three subpoints, to be non-maleficent has to do with your intentions, your acts, and the outcome of your act. So first of all, ethics cannot help but be concerned with your intentions, with your feelings, and with your desires about the good. And our professional responsibility is not just a responsibility to sort of act in accordance to guidelines, but is to desire, to intend the good for other people. And there are certain strands in modern philosophy and utilitarianism that say, ethics is just about outcomes, it's just about ends. But that is, I think, rather straightforwardly not true. And I can demonstrate that to you using an example. So this is a picture, a cartoon picture of someone with anaphylaxis. So let's say someone comes into the emergency department and they have a significant infection, and I give them a dose of IV ceftriaxone, which is an antibiotic. And then the patient has a significant anaphylactic reaction and let's say has some kind of a bad outcome with significant morbidity because of the anaphylactic reaction specifically. Now, that act of myself obviously produced a bad outcome. But if I did not know the patient had an allergy to ceftriaxone, there was no indication of a similar allergy, I had a careful look through her chart, and this was just one of those unpredictable tragedies, and ceftriaxone was the right antibiotic to give her, there is nothing unethical about what I did. But let us say, in a horrible situation, that I, for some reason, knew that this patient had an allergy to ceftriaxone and gave it to her anyway, with some intent to harm her. The act itself would be the same, and the outcome would be the same, but obviously that would be a grossly, horribly unethical thing to do. And so ethics must unavoidably relate to our intent when we encounter patients. And here's just a very brief sort of high philosophical quote that I think is really good, that says, ethics cannot help but concern itself with the cultivation of desire, with learning to desire, and I say the good for the other, because the other is truly desirable, because every other is truly beautiful. The moral task is to love because one truly sees, and so see because one truly loves. To educate vision to see the glory of this particular one. The most moral of labors is that of being moved to love by the infinite particularity of the other, and to be drawn out into a distance determined by and shared with the other. So non-maleficence and not harming other people is not just about outcomes, but it's about how you feel. I'm going to skip these ones just for the sake of time. And I think one example of this is patients leaving, let's say, the emergency department, for example, because that's the context where I work in, against medical advice. So we see all the time in our emergency department, patients who come in to our emergency department who are sick, but who at some point, for a variety of reasons, say, I'm not staying and I'm leaving. And oftentimes, especially when those patients are difficult to deal with or difficult to care for one reason or another, the attitude of certainly, the attitude, and I think these internet memes are reflective of this, sometimes is less than sad. Because if there is a patient who is difficult to care for, who leaves the department, there sometimes is the temptation to say, oh, that's a relief because I now, don't have to engage in this difficult caring space anymore. I want to say that temptation is a temptation that is maleficent. That the principle of non-maleficence placed in our actual care spaces calls us and compels us to a duty to yearn for the good for our patients, to really care. And so a patient who's sick who wants to leave, our responsibility is not just about the guidelines of getting them to sign a form saying they acknowledge the risks or whatever of leaving against medical advice. Our non-maleficent responsibility is to desire their good, to lean in, to try to understand, engage, build trust, to desire the good for them, even if it means more difficulty in our day. Secondly, non-maleficence is not just about what we desire, it's about what we do. There are certain acts that are, I think, in particular professional context, inherently contrary to a particular view of the good. And one interesting example of this is in the United States, as many of you will know, capital punishment is legal in several, I don't know the exact number, a reasonable number of states. And in most, if not all of those states, the state governments or the political powers that be have asked the anesthetists and sometimes put considerable pressure on anesthetists to be the ones who sort of enact the capital punishment on patients who are condemned to die. And their argument is, this outcome is assured, the patient's going to die this way anyway, and you have the know-how to do so in the most sort of comfortable fashion. And so you have an ethical responsibility as physicians to participate in this. And across the board, and I think in some cases, like very, very courageously, the American Society of Anesthetists and in the individual states have declined and even refused to be involved in these so-called procedures. And they say, although lethal injection mimics certain technical aspects of the practice of anesthesia, capital punishment in any form is not the practice of medicine. Because of ancient and modern principles of medical ethics, legal execution should not necessitate participation by an anesthesiologist or any other physician. And I think this is a good example of the way that non-maleficence is about our intent, our desire. It is also about carefully considering the particular act in question and whether or not that act is in keeping with the particular practice of medicine. We're going to skip over this for time. Thirdly, and critically importantly, non-maleficence absolutely also has to do with outcome. So just because it's not all about outcomes, that doesn't mean that it's not about outcomes at all. And this opens up a conversation that hopefully we'll have in a seminar down the line to sort of dive more into harm reduction theories and this responsibility to prevent harm. But to use an example like naloxone kits with the tragedy of the ongoing public health crisis around substances in our community. We have a responsibility to do a careful research and thinking about what produces good outcomes. And we know that distributing harm reduction supplies like naloxone kits produces better outcomes and saves lives amongst people who are at high risk for a variety of reasons. And therefore, I think straightforwardly, the principle of non-maleficence suggests that we need to invest in measures like this. So non-maleficence has to do with our ongoing responsibility to try to learn and understand what produces good health outcomes in our patients and to tirelessly seek those things. So as usual, I'm running up against my time, unfortunately. I want to briefly just conclude by considering these 5 cases, and again, encouraging you to think carefully through these particular common medical situations. And when you think about what it means to be non-maleficent, think about it in respect to a particular view of the good. And that is the end.
Thank you, Quentin. Another thought-provoking seminar. I really appreciate it. And the use of time really speaks to your passion for this. So we really thank you for that. I just want to address one question in the Q&A, just for interest of time and make sure this person gets their question answered. There was a question about whether or not there's going to be an extra session added because Quentin added this one. The answer is no. We're just going to be compressing a couple of the last sessions. Quentin, a good question for you that was brought up. Can you comment on how non-maleficence plays out when we're thinking about doing a procedure that a person without capacity doesn't want? So for example, the temporary substitute decision maker has provided consent, but the person who is not capable is telling us that they don't want a procedure. And how do we balance that?
Yeah, thanks for that excellent question. I think ethically, I would want to emphasize taking the patient without capacity seriously. And I think sometimes people can think too algorithmically about capacity and say, you know, someone who has capacity, their wishes have ethical weight, and someone who doesn't have capacity, their wishes have no ethical weight, therefore it doesn't matter. And I would want to say that someone who doesn't have capacity still has dignity, and the things that produce fear or pain in them, or things that run against their wishes, there is still significant ethical weight to that and a real responsibility to try to build trust. And these are situations where there's obviously going to be an assessment of proportion depending on how critical the procedure is. And also, I would say the situation where the patient does have capacity, like I think there's situations, for example, delirium, when the patient temporarily doesn't have a capacity, or significant substance intoxication. But you know that, you know, based with appropriate treatment in a short period of time, the patient will have capacity again and will presumably want that particular intervention. I think that's different than a case where someone has a different diagnosis and likely for the foreseeable future will not have capacity. In terms of the responsibilities you have, I would say in the second situation, you have a real higher responsibility to carefully engage with the individual in terms and framework that's understandable to them, to try to build trust.
That's a beautiful answer. Thank you so much again for your time today. I'm conscious we're right on the mark of 1 o'clock. So I think we'll wrap it up there. Quentin, that was another wonderful topic, and we're so grateful to have learned from you today. So thank you so much.
Thanks. Try to be shorter next time. I'll do my best.
No.
Thanks, Denise.
Thank you. Thanks, everyone.